بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد آخر الأنبياء وأكرم المرسلين. I'd like to welcome all of you coming after lunch or sometimes without lunch, coming for the third session of the 6th Saudi Hypertension Management Society Congress. We appreciate the active participation of all of you, and we are very happy with the speakers. I mean, we are happy that we have international speakers. They are participating in our meeting from Turkey, from Lebanon, from Italy, from multiple places. So we'll be starting, we don't want to have more delay. We'll be starting the third session today, and I'll be chairing the session, and Professor Roberto Ferrari will be the co-chairman of the third session of the Congress. We'll have the first presentation of this third session by Dr. Tawfiq Al-Bassam. Dr. Tawfiq Al-Bassam, he's consultant internist and he's expert in hypertension. And he's one of the active members of Shams Group, and he's member of the board of Shams. He will be talking about very important subject, which is resistant hypertension, how to diagnose, how to manage. He will be presenting by 20 minutes, and after that, we'll go to the second speaker. The discussion will be at the end of all the presentations. Dr. Tawfiq, thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Walid, for this organization and for inviting me. I know we are a little bit late, but what will I do? I'll go fast on certain points, and I will slow down important points. This is my disclosure, and this is the objective of my presentation. I review the different terminology, mechanism involved in resistant hypertension, patient evaluation, treatment resistant, and knowledge gaps, and future research. Now, definition. We all started in JNC 2003, where they had this definition: optimal doses of 3 or more anti-hypertensive medication, including diuretic. The AHA 2008 had their statement almost similar. Then we had a modified definition according to 2017 hypertension guideline, the Americans, where they suggested that the office blood pressure above goal, sorry. Thank you. So this is the modified definition according to the new guidelines. They stated that the office is at least 130 or 80 or more, 3 or more drugs. Then they said we should exclude white coat effect. They need to exclude non-adherence. And they also defined somebody who's at goal with 4 drugs as being resistant. Now, we had also the AHA scientific statement 2018, where it said that above goal, despite the current use of 3 antihypertensive drugs, including RAS blockade, diuretics, CCB, at maximum tolerated doses, and those achieve target on more than 3 antihypertensive medication. They had to exclude non-adherence and exclude the non-white coat effect. Now, the European definition, they kept it more or less the same target, less than 140/90. Again, they stressed the importance of appropriate lifestyle measures and medications of 3 or more, including these medication. It should be confirmed by out of the office. Adherence medication is confirmed, exclude soda resistance, and exclude secondary causes. Then we came up to a definition called refractory hypertension. Again, this definition has evolved first it was used interchangeably with resistant hypertension. Then they said it is a failure to achieve blood pressure goal despite maximal antihypertensive therapy. And then they added a statement, it's failure to achieve goal with a treatment prescribed by hypertension expert at a minimum 3 follow-up visits during 6-month care. They are telling us that this refractory hypertensive patient is a more advanced case of resistant hypertension. It has to be more to acquire this definition. Then we are using ambulatory blood pressure nowadays, and we are having these terms: uncontrolled resistant hypertension, controlled resistant hypertension, white coat hypertension, and masked resistant hypertension. Prevalence, probably from 8 to 12 in the primary care, probably about 11-21% specialized referral center. The prevalence expected to increase after the new guidelines, and the prevalence of refractory hypertension is about 3%. So it's always refractory hypertension less prevalent than resistant hypertension. This is the unhinged resistant hypertension. Again, the prevalence rate compared goes with about 10%. Now, the mechanism, again, the exact mechanism we still do not know. However, we do know there is volume overload, enhanced sympathetic activity, increased RAS, arterial stiffness, endothelial dysfunction, and now there is emerging factors such as microbiota, air pollution, and sleep disturbance. When I talk about sleep disturbance, it's not obstructive sleep apnea, it is something else. Whether you're having too much sleep, too little sleep, or insomnia, both probably they make your blood pressure resistant. Now, what is the implication? The high risk of morbidity and mortality, and higher risk of medication adverse effect. Now, there are certain clues in patients which suggest that patient has resistant hypertension. They are high baseline blood pressure, African American race, obesity, diabetes, elderly, and these are the rest. All these give us a clue that this kind of hypertension patient may be having a resistant hypertension. Diagnosis, again, simply stated, we start with the history, we start with the lifestyle status, the diet, interfering substance, sleep quality. We need to confirm it by out of the office. Examination, focus on target organ damage, secondary causes. If you examine a patient supposed to be resistant hypertension, and there are no target organ damage, probably the diagnosis is wrong. So keep this in mind, the association between target organ damage and resistant hypertension. We need to also assess for secondary causes, confirm adherence to medication, exclude pseudo-resistant. By the term pseudo-resistant is a wide term, includes a lot of statements, a lot of this. These are what we'll talk about, which I'll come to these later. There are certain drugs which induce hypertension and probably makes the blood pressure uncontrolled. These are the drugs we should be aware of. Many of them are prescribed, and there is also the non-prescribed cocaine and so on. Now, adherence is an important topic in resistant hypertension. We must exclude before we confirm this patient has resistant hypertension. And we have a statistic that up to 40% of the newly diagnosed hypertensive will discontinue their medication during the first year. How do we measure adherence? We have the direct measures and we have the indirect measures. Of course, the direct measures, most of them complicated, they are not available, and they are costly. We cannot use them. The indirect measures, these are the ones, on most of them, they are not good enough to pick up the resistant hypertension patient. How do we improve adherence? Education, teach the patients, simplify medication regimen, utilize fixed dose, family support. Now, therapeutic inertia used to be terminology which is rare, we don't see. But actually, now the studies suggest that therapeutic inertia is an important cause of resistant hypertension, and the effect of therapeutic inertia, it makes your blood pressure uncontrolled. If we come to secondary causes, we know they play a good part in resistant hypertension. These are the list of the causes. What are the clues for the causes? Age of onset, younger age, elderly, worsening of hypertension, presence of extensive target organ damage, clinical clues, and laboratory clues. Treatment modality in hypertension, non-pharmacological, pharmacological intervention. I will not talk about non-pharmacological, it's already covered. Pharmacological therapy. Now here we expect the patient already on 3 drugs, including a RAS blockade, CCB, and diuretic. So we start from there. What we can do first step, modify the diuretic regimen, intensify the dose of the existing diuretic, switch to chlorthalidone or indamamide, or switch to a loop diuretic. This is important to consider before you starting the next step. This is based on evidence that chlorthalidone is more effective than hydrochlorothiazide in blood pressure reduction. And we have a meta-analysis showing that these thiazide-like diuretics probably have better benefit and protect patients from events. Step 2, we add spironolactone. We all know now spironolactone is a very, very advantageous in this state. We already have the evidence far away, but now we have the trial, Pathway 2 trial, which really confirmed that spironolactone among these drugs is the most one that reduces blood pressure in resistant hypertension. Now, if the patient is allergic or cannot tolerate the side effects of spironolactone, the alternatives, eplerenone or amiloride. If we fail to do that, then we come to the territory where there is no evidence. Actually, we need the experience of the doctors. Beta blocker, the heart rate is more than 70, they will help. Vasodilating beta blockers are advised. Central alpha-2 agonists like clonidine, alpha blockers, doxorubicin, of course the direct vasodilators like hydralazine and minoxidil. They are very, very effective, especially in CKD patients. But they do have their side effects. Now, another point, the single pill combination. This is very helpful here in control of their patient. It's associated with better adherence. Regimen, initial prescription leads to a better blood control. And we have key studies which confirm that. And we have enough data to suggest that the fixed dose combination have been shown to improve adherence. They have advantages, yet they have disadvantages. But if they are available and affordable, I think we should start with them. Now, we expect new drugs in the horizon, including the counter-regularity of the RAS pathway, like ACE2 activators, angiotensin receptor agonists, angiotensin 1-sep analogs, MAS activators. We have the nitrotic peptides, we have the mineralocorticoid receptor, and we have the aldosterone synthase inhibitors, and our donors and vaccine. Now, the vaccines used to be important because we could prevent people from getting to a stage of resistant hypertension. But up to now, most of the trials, the evidence does not prove it yet. Interventional therapy. There will be a time that drug therapy may not be able to achieve lower blood pressure targets. Patient might not be able to take multiple drugs. Thus, we need strategies to reach our blood pressure goal. The most three interventional therapy: renal denervation, baroreceptor activating, and central arteriovenous fistula. The first one, I will not talk about it because we're going to have a presentation on this, so I will skip to that. It's just point that it used to be the most studied procedure, but we had a problem in one of the trials, which almost stopped everything. We are having a new generation of trials, which is probably going to come back again. The baroreceptor activation therapy, this is based on implantation of electric stimulator to activate the baroreceptors. We have the carotid sinus stimulation, and we have two evidence, Rios pivotal trial. What they do, they implant two electrodes along the baroreceptors, and they have here a generator, and they try to activate the baroreceptors. When doing that, the blood pressure will get lowered. This is the trial what they tried, and this is the result. In the first 6 months, the people who did not use this receptor activation did not get your blood pressure reduction. After 6 months, all the groups did that. Again, same value. Then it was modified. Instead of having 2 electrodes, we went for 1 electrode, smaller device. And again, that was effective. But it has its disadvantages. It is still invasive, costly. It has its side effects, and probably need a battery replacement every 4 and 5 months. Then they came up with a new way, the so-called intravascular baroreflex amplification. What they did actually is they placed internal carotid artery, specially developed delivery catheter. It is where the baroreceptors are there. And I don't have, really doesn't work, but this is on the right side. It is inserted in the area of the baroreceptors, and did prove that systolic and diastolic blood pressure go down. Finally, we have the so-called central arteriovenous anastomosis. What they did is they had sort of a connected by a Rock's cobbler fistula between the iliac artery and iliac vein. In doing so, they relieve the high pressure circulatory part to the venous side. That means they decrease blood pressure. And this is a sketch of how they did it. And this is the way they lowered blood pressure. They have other effects: increased cardiac output, increased arterial pressure, increased compliance. And the trial was small, but it did show a benefit. I'm going fast because of time-wise. This is my last slide. Still research challenges and need. The pathophysiology of resistant hypertension is not clear. The genetic basis of resistant hypertension to be uncovered. We still don't know a lot. Environmental influences. Does air pollution, microbiota, sleep really affect hypertension? We need to identify adherence, and we need to overcome adherence. And finally, what is the optimal target in resistant hypertension? We don't know. There is no study which tells us what is the target we should. We have plenty of data or knowledge we need to fill. This is my last slide. Thank you for listening.
Thank you very much, Dr. Tawfiq. Excellent presentation. We'll keep questions to the end of the session. We'd like to call for the next speaker. Next speaker is Professor Mustafa Kemal Erol. Professor Mustafa is Professor of Cardiology at University in Istanbul, and he's the President of the Turkish Society of Cardiology. He will be addressing very important session about renal denervation, the indication, the need, and the guidelines. I mean, we have also workshop in the other rooms, if anybody also attending the workshop. I mean, we are very happy to have good relationship with the Turkish Society of Cardiology. We started with this one almost 2 years ago, and we'll continue. We'll try to upgrade it every now and then. We'll be very happy to have Professor Mustafa with the coming presentation, and we'll keep the questions to the end. His presentation is related sometimes to hypertension resistance and the management. So we'll see according to the presentation. Professor Mustafa.
Thank you, Walid. Selamun Aleyküm. Bismillahirrahmanirrahim. I should say before my speak, it's very pleased to be here. Yes. Okay. It's great pleasure to be here for me, and I thank you, my close friend, Professor Walid Pisata, to inviting on behalf of organizing committee for inviting me this conference. My topic is renal denervation of resistant hypertension. I have no conflict of interest about this topic. As we know, hypertension is a very prevalent disease in a major global health problem. For example, in my country, 30% of adults have hypertension, and its prevalence is increasing with the age, and every 2/3 of people has hypertension over than 70s. And it is associated with increased cardiovascular morbidity and mortality. We have a lot of medicine from different groups that acting different way to decrease blood pressure. Despite multiple antihypertensive drug combination, we cannot decrease blood pressure to below the target levels in some patients. Approximately 50% of patients with hypertension have suboptimal control of their blood pressure. There are several reasons for this, such as inadequate lifestyle measures, poor drug adherence, and secondary hypertensions. Resistant hypertension is defined blood pressure higher than 140 to 90 millimeter mercury, despite 3 or more antihypertensive drug combination, including a diuretic. The exact prevalence of resistant hypertension is not known. It's reported broad range from the studies. In studies using ambulatory blood pressure measurements, prevalence is lower due to the exclusion of white coat effect than studies using office blood pressure. Resistant cardiovascular and renal risk is higher in patients with resistant hypertension, and we need new therapeutic options in this group patient to decrease blood pressure to target levels. In this regard, renal denervation has been an important clinical research focus in the last decades. When we look at the pathophysiology, both renal afferent and efferent signals play a key role in blood pressure regulation and pathogenesis of hypertension. The efferent sympathetic signaling from brain to the kidney cause cause hypertension, blood pressure increasing effect via 3 major mechanisms. First, the signal, afferent sympathetic signal, increases the renal vascular resistance and vasoconstriction of renal artery, and reduction of renal blood flow, and reduction of glomerular filtration rate. The second, it causes increasing production of renin from juxtaglomerular apparatus, thus activation of renin-angiotensin-aldosterone system. The third one, it's increase the renal tubular sodium and water reabsorption. Conversely, increased efferent stimulus from kidney to the brain by triggered renal ischemia, renal inflammatory and fibrotic process lead to increased sympathetic nervous system activity in centrally. Thus, interruption of brain to kidney connection has a potential role of decreasing blood pressure via increases blood pressure flow and increases glomerular filtration rate, decreases renin secretion and blurring of renin-angiotensin-aldosterone cascade, and increasing of tubular sodium and water excretion. Actually, this topic is not new. It has been known for a long period. In the history, in 1930s and 1940s, non-selective surgical sympathectomy was used, and an effective substantial blood pressure decrease obtained in patients with malignant hypertension patients. Unfortunately, these benefits was offset by significant operative complication and several side effects such as postural hypertension, hyperhidrosis, sensorial and sexual dysfunction. When effective antihypertensive medication became available in 1950s, surgical denervation was abandoned due to several complications and side effects. But, however, this historical operation provided proof in principle evidence for renal denervation in treatment of resistant hypertension. In last decade, better understanding of sympathetic system and advent of transcatheter techniques emerged the renal denervation in treatment of hypertension again. The renal sympathetic denervation has evolved into three unique strategies. First, radiofrequency ablation. The second, ultrasonic ablation. Third one, tissue-directed pharmacologic ablation. Catheter-based renal denervation involves inserting a catheter into the renal artery, which allows ablation of periarterial sympathetic nerve cauterization. Different types of catheters used up to now. This is Adrian catheter, a first example of radiofrequency catheter, simplicity flex catheter. This catheter has a flex tip and there is only one radiofrequency electrode on tip of it. This catheter is placed distal main renal artery after 2 minutes catheterization. Catheter pulled back at 5 mm proximal and rotated 45 degree for the new position manually, and 46 ablations are applied to each renal artery. This catheter was tested Simplicity HTM1 study in 45 resistant hypertensive patients. Primary endpoint were the blood pressure change from the baseline. As you can see here, after renal denervation with this catheter, at the end of first month, both systolic and diastolic blood pressure decreases significantly, and further decreases and at the end of third month, and followed up to 1 year. There was no reported serious adverse event. In multicenter prospective randomized Simplicity HTN2 study, patients with resistant hypertension were randomized renal denervation plus medical treatment and medical treatment. And as you can see here, in renal denervation, decreased blood pressure in systolic 32 mm mercury, in diastolic 12 mm mercury. Compared to baseline, this difference is very significant. In medical arm, there were no change. And this study, the follow-up this study, this decrease continued up to 3 years. And this study, after 6 months, crossover control group to the renal denervation group allowed, and in those patients after underwent the renal denervation, the same blood pressure reduction occurred. This is another radiofrequency catheter produced by Saint Jude. This catheter is N-light catheter, has a basket-like tip, and there are 4 electrodes on it, can allow circular and circumferential ablation renal artery. This catheter was tested N-light 1 study. As you can see here, both systolic and diastolic blood pressure decreased significantly in end of the first month, and persisted up to 1 year, both in office blood pressure measurement and ambulatory blood pressure measurement. Overall, these three trials suggest that renal denervation with radiofrequency catheter was effective in reducing and sustaining reduction of blood pressure and relatively safe without serious adverse event. But there was no sham control in those studies, and which means that a placebo effect could not be discounted. And significant concern were raised about the adherence and compliance during these trials, which could have an influenced outcome. The first sham control study was simply the HTN-3 trial. In this trial, patients with resistant hypertension randomized renal denervation and sham control groups. In the sham control groups, renal puncture was done and renal angiography was done, but not renal denervation. And as you can see here, this trial results showed us systolic blood pressure decreases significantly, both renal denervation and sham control groups compared to baseline, but there was no difference between sham control and renal denervation group. When we look at the subgroup analysis, this study, in subgroup of white people and subgroup of people younger than 65 years old, renal denervation was better than sham controls. After the publication of